Okay, so let's talk about the preload first. So we kind of already touched on this. So the way I like to think about this is I say, okay, here's my venous circulation. Okay, so we're just going to say venous circulation. We'll put a blood vessel here. Now this venous circulation is going to drain where? Into the right atrium, right? And that blood is eventually going to go through the lungs. Okay, it's going to come out oxygenated from the lungs, and it's going to go to the left side of the heart, and eventually go to the left ventricle. Eventually it's going to go to the aorta, and now we're on the arterial side. We'll draw another blood vessel here, and eventually these guys are going to meet up right at the capillaries. Okay, so the capillaries, and that's the site of where the oxygen is going to diffuse across to the organs or to the muscle, and then we'll end up with deoxygenated blood coming back to the venous side. Okay, so that's the general concept of what's happening here. Okay, that's how I think about it. And it helps to kind of think about it like this to understand the preload and the afterload. So the preload, again, is the blood that's returning. So here's going to be my preload. It's this blood coming back to the right atrium. Now, if I have more blood coming back to the right atrium, I'm going to have more filling eventually of my left ventricle, right? Because if I have more blood coming to the venous side, more blood to the right atrium, to the right ventricle, to the pulmonary artery, more blood through the pulmonary veins, to the left atrium, to the left ventricle. In general, there's going to be more blood coming through here if I have more blood returning in the venous circulation. Okay, again, preload is synonymous with venous return. The more venous return you have, right, the more preload you have, and the more end diastolic volume you have. That's why the end diastolic volume is synonymous with the preload. When we say that the preload goes up, we're saying the end diastolic volume is going up. What's the formula for stroke volume? It's end diastolic volume minus end systolic volume. If I increase the end diastolic volume because I have more venous return, that's going to cause the stroke volume to go up, according to this equation, right? Because I'm going to have more blood in the left ventricle. If I have more blood returning to the left ventricle, then I'm going to have likely more blood being ejected. Why is that? Why is it when I have more blood that comes back to the left ventricle, I have more blood that's ejected? What happens is the preload is actually related to the left ventricular chamber volume. And so as the left ventricle dilates to accommodate more blood, okay, as the left ventricle dilates to accommodate more blood, what's happening here at the myocardial cells is the sarcomeres are going to lengthen. Okay, so you're going to have sarcomere lengthening that's occurring as you accommodate more blood here in the left ventricle, up to a degree. In general, though, as I bring more blood to the left ventricle, as my preload goes up, my stroke volume will go up, as will my contractility. The contractility is going to go up because we have this sarcomere lengthening occurring, causing more forceful contractions. So in general, we can say that the preload, as the preload goes up, it's going to increase the stroke volume. Okay, so that's the big point. As the preload goes up, the stroke volume will go up. Okay, so we'll just put a plus sign here. Now, what happens if I give a patient something like a nitrate? Okay, so nitrates, let's write that in here. Nitrates actually cause venous dilation. Okay, so these are going to cause the veins to dilate. Now you have to be careful because we have drugs that are arterial dilators, we have drugs that are venous dilators, we have drugs that are arterial constrictors, we have venous constrictors. They don't do the same thing, as you'll see, right? Nitrates can cause a little bit of arterial dilation, but on board questions, they're usually testing you on its effects on the venous side. So if I cause venous dilation, am I going to get more blood or less blood coming back to the heart? I am going to get less blood coming back to the heart, less preload, okay? And that's because when I dilate here, I want you to think of the venous side, this whole thing, I want you to think of it as a big refrigerator or storage container or storage unit or something like that, where it's storing all of this blood. The arterial side is kind of like your highways. You got blood, moving all over the place just to get to a tissue that requires oxygenation, right? But in the venous side, we're just accommodating the blood until it gets back to the right atrium. We're just hanging on to it for a little while. It's not really moving very fast, right? There's not a lot of pressure going on here. When I dilate, I'm allowing the venous side to increase in compliance, okay, because I want it to accommodate more blood when I dilate. Okay, so venodilation is going to increase the compliance and allow me to hold more blood, but it's going to decrease the preload. okay, because less blood's going to come back. Now, conversely, if I have venous constriction, I'm going to get a decrease in compliance, right, because I want those vessels really small. They're going to be constricted, and I'm going to get more preload because I'm going to be constricting this blood, shunting this blood back up to the right atrium, okay? So that's the concept. Now, nitrates, venodilation, how does that help the heart? We'll talk about all this in the angina lecture, but the idea here is I'm going to have less blood coming back to the heart, less blood going to the left ventricle, and that's, again, less preload, less end diastolic volume, right, with less end diastolic pressure in the left ventricle, and that's going to decrease myocardial oxygen demand because there's going to be less shear stresses on the left ventricular wall. That's why we use nitrates for angina. Now, afterload is primarily referring to the total peripheral resistance, which I'll talk about in a minute. Now, just be careful. In board questions, they can tell you total peripheral resistance or systemic vascular resistance. For board question purposes, you can think of these two as the same thing. The TPR, the SVR, they're the same thing. And they're both synonymous with afterload. When one goes up, the other one goes up. So what is this TPR and afterload? So here's my arterial side, right? So this is going to be the arterial side. And when I'm thinking about afterload, I want you to think more about the arterial side over here. If I increase the total peripheral resistance, I'm going to do that at a very specific area. It's going to be at the arterioles. Okay, and that's particularly high yield to remember. So the total peripheral resistance is really going to be dictated by the arterioles here. Okay, now if the arterioles vasoconstrict, that will increase the resistance, right? Because that's going to leave less room for blood to move. It's going to increase the pressure. Okay, particularly what pressure? Particularly the diastolic blood pressure. So if the TPR goes up, the diastolic blood pressure will likely also go up. Okay, so that's another thing to kind of remember. Sometimes you can correlate the TPR with the diastolic blood pressure, and specifically, again, this is all regulated at arterioles. TPR goes up, we're primarily talking about vasoconstriction. Okay, and then the opposite is true for vasodilation. If I have widespread vasodilation, my diastolic pressures would probably be lower, and that would also be a lower afterload. Now, remember, the heart has to pump against this pressure. It's got to get the blood from the left ventricle into the arterial space. So if the pressure is a lot higher on this side, if my pressure is very high, it's going to be a lot harder to get that blood out of the left ventricle. So as the afterload, as the TPR goes up, the end systolic volume will be higher. Why is that? Because at the end of systole, I'm going to have more volume because I couldn't get as much volume pumped against this high pressure, right? If the pressure is really high, there's not as much volume that's going to be able to go to that side. It's going to come back or it won't go at all. And so that's going to cause a lower stroke volume because, again, look at the equation. If I have a higher end systolic volume, I'll end up with a lower stroke volume. Okay, so afterload is actually going to have the opposite effect of the preload, that is on the stroke volume. So as afterload goes up, the stroke volume will go down. And just to give you an idea here, in a healthy heart, if things are working normally, if my afterload goes up, usually my preload will go up. Okay, if this goes up, this will actually go up to compensate so that I can maintain my stroke volume, okay? But I'm not going to go into too much detail on that, but really where the afterload has a pretty dominant effect is in heart failure, and we'll talk about that in a little bit. Remember, I talked about nitrates a minute ago causing venous dilation. Now, on the arterial side, we're talking more about arterial vasodilators. So you might say, okay, like what? Hydralazine is the big one. Okay, so hydralazine is a arterial vasodilator. So hydralazine is primarily going to affect the TPR. Is it going to raise it or lower it? It's going to lower it because it's a vasodilator. Whereas nitrates are a venous dilator. When they're dilating the venous side, what are they going to do to the preload? They're going to lower the preload. So this is why I like to think of things in this diagram, because then I can say, okay, where is it acting? And then we can figure out what it's doing. So arterial side, we're thinking about total peripheral resistance. Venous side, we're thinking about preload. We went to both sides. Let's just jump in the middle. And in the middle, right, we have the heart. Okay, so in the middle we have the heart, and when we're thinking about this area, we're thinking about contractility. Now, what are some things that can impact contractility? There's a couple things. The biggest one, though, is going to be increases in sympathetic nervous system activity, particularly things like catecholamines, things that have beta agonist activity, like epinephrine, for example. So if you want to put things in layman's terms, contractility is essentially how hard the heart is beating, okay? And this is going to cause, if I increase my contractility, what's going to happen to my end systolic volume? We just kind of talked about this. It's going to be lower because I'm ejecting more blood from the heart. If I lower, again, going back to our equation, if I lower the end systolic volume, then my stroke volume will be higher, right? That's the concept. So contractility also impacts the stroke volume. If I have a higher contractility, think about it intuitively. I'm going to eject more blood from the heart. And so contractility, much like preload, is going to be proportional to stroke volume. So when contractility and preload go up, the stroke volume will go up. When the afterload goes up, the stroke volume generally will go down. What, in terms of contractility, what is the classic agent that you would think about? The big one is going to be digoxin. Okay, so when we talk about contractility, a lot of questions are written about digoxin, which is typically given if a patient has left ventricular systolic dysfunction. In other words, they have reduced contractility. So we give it to increase the contractility. I don't want to go into too much detail on the law of Laplace because, we can be here for a long time talking about this. So if we have, some increased pressure, let's say we have a patient that has hypertension. And so we're consistently delivering a higher pressure to the left ventricle. Well, what can happen over time? We can increase the wall thickness to compensate for the wall stress. Right? If I have a really high blood pressure, and I have really poorly controlled hypertension, physiologically, I might respond to that. My heart might respond to that by increasing the wall thickness. Okay, and typically this would be done with sarcomeres in parallel. Okay, so if I put sarcomeres in parallel, I can increase the thickness of my myocardial wall, which would lower the wall stress. So it's compensating for this increase in pressure that's causing an increase in wall stress. If I increase the wall thickness, I can get that wall stress back down. This is essentially what we see in diastolic heart failure. Okay, patients typically will have diastolic heart failure in a thickened left ventricle from chronic hypertension. It's very classic. Okay, and the idea here is more sarcomere units are available to sustain the impact of this added wall tension. So the thicker the wall, the less tension experienced by each sarcomere unit. And you might be saying, well, what about systolic heart failure? Well, you can actually even apply this equation to that as well, right? If you have systolic heart failure, that's a dilated cardiomyopathy. So in other words, the chamber of the heart is going to be dilated, right? The radius goes up, so the wall stress will go up. So it's a similar problem that you're running into in both scenarios. And I'll talk more about this in the heart failure video.